Welcome to the University of Washington and the Office of Public Lectures special weekly series, Coexisting with COVID. I'm Hanson Hossein, co-director of the Communication Leadership Master's Program and your host over the next few weeks. Every Thursday, with the help of some of the UW's top experts, we'll explore what could be the new normal as we adapt to the ongoing disruption of the COVID-19 pandemic. We're doing so in partnership with the Graduate School, UW Marketing and Communications, the Population Health Initiative, UW Video, and my own Department of Communication. This evening, COVID-19 and the failures of the public safety net. This pandemic has been a shock to the system. It has exposed the fragility of how we've agreed to care for each other. But does this painful lesson also give us a chance to get it right? As you registered for this conversation, we ask you to use the Thought Exchange platform to respond to this prompt. What surprised you the most about the gaps in service from social safety net providers? We'll be using Thought Exchange later for your questions to our guests. Joining us for this timely conversation are Aaron Katz, Edwin Guillermo Lindo, and Graham Press. Graham is a lecturer at UW Medical Anthropology. He has studied vehicle residency and homelessness over the past decade. Graham has not only served as a leader on King County's coordinating agency, All Home, he was also once an unhoused youth and later a social service outreach provider to all vehicle residents in Seattle. Edwin is a lecturer in the Department of Family Medicine at UW Medicine. He has taught and researched critical race theory and anti-racism. Edwin looked very specifically at the effects of racism on healthcare within communities of color. He also hosts the podcast Praxis that examines health justice. And Aaron is a principal lecturer in the UW's Department of Health Services. He has deep expertise in healthcare and public health policy, and very specifically in the healthcare safety net, or lack thereof. Aaron has an appointment to the Department of Global Health and has served as the director of the Population Leadership Program. What would you like to ask our panelists? Use the Thought Exchange platform to submit your questions and/or vote on which questions are most important to you. It's important that we hear from you for the second half of our time together, so please do use the QR code you see on your screen to share your thoughts. You can even snap a photo of that QR code with your smartphone. Welcome, Edwin, Aaron, and Graham. And well, according to our Thought Exchange icebreaker question, our audience is wondering whether these gaps in the social safety net have always existed or has COVID-19 just made them worse, especially around the impact on essential workers, communities of color, and the homeless. And in contrast, I read this today in the Harvard Business Review, COVID-19 is showing that much that we believed was wrong, things that seemed impossible a few months ago, have suddenly come to pass. And that includes societies divided by politics and inequality can quickly come together in shows of mass solidarity. Now, the three of you have been on the front lines of this for so long, and the title of this show is Failures in the Public Safety Net. So how do you think it's going so far? I think I'll start with you, Aaron, since you're a public health expert, and this is a public health emergency. What do you say?
Yeah, I think this epidemic has revealed lots of gaps in the safety net, and in fact, the basic structures of our society. I would say there's two things that strike me: one positive and one negative. I'll start with the negative, and that is, the epidemic has really shown in bright light how the underfunding of the public health system over the last 30 or 40 years brought us to this place of being horribly unprepared to address the coronavirus epidemic. We've been underfunding local and state public health agencies. In fact, there's one estimate that these agencies have lost as many as 50,000 staff over the last several decades. So we just weren't prepared, and we have to fund that system if we're going to be well prepared for the next one. I would say the positive thing that has struck me is the level of public support for the public health measures that states have taken over the last couple of months. Levels of support that are far exceeding, for example, support for either political party. 60 to 80% of of the public in various states have supported these public health interventions. So that gives me some hope.
It's surprising, actually, Aaron, because you're right to look at that hopeful statistic. Because a third of the world, at least, is in social distance mode right now, which means they're listening to the experts, they're listening to their leaders, despite all the things we've heard about polarization and dysfunction in our society.
Right. I think that's a remarkable achievement, despite the sort of flashes of the headlines.
Yeah. Edwin, you've heard Aaron talk about both the positive and the negative, that we weren't prepared, that we are underfunded, but there is some hope. You've been focusing specifically around health and communities of color, where the underfunding and access have been endemic. How do you think we're doing so far as you've seen this crisis take hold?
Well, if we look at the media, we look at the data that's been presented to us, it doesn't look good at all. Just a few days ago, there's a study done in the Mission District where I grew up in San Francisco, and it took a census tract in the Mission District, which is predominantly Latino, Latinx folks, but they only make up 30% of that population, yet 99% of the tests positive of COVID-19 were Latinx community members, right? We see that around the country. We look at communities in the South where a high level of mortalities are overwhelmingly and disproportionately Black. It's not an accident. Right? It's not an accident at all. I think we look at it and we say, why are these bad things happening? Why are they affecting these communities so much? And I think it's why I do the work that I do, because we have to examine the inequities, the structural and institutional racism that has not only been a legacy, but the residue of it continues to seep into our society today, which leads to the decrepit safety net that we have. And why I think ideas and thoughts of the years past of having universal basic income, of being able to provide testing to communities or a basic salary were unfathomable. And yet now our government has shown to have the political will to say, well, we have to do it because we need to survive. These are things that communities of color, marginalized communities have been asking for because the history of redlining, of environmental racism has led to the underpinnings of chronic illnesses at a higher rate in these communities, which then leads to the disproportionate effect when they walk into the clinic testing positive for COVID-19.
I also have to ask you, the disproportionate impact on these communities of color is not just because of the things you've identified, but disproportionately the frontline workers who are in these health systems are from communities of color as well. Could you maybe explain a little bit more around that?
Yeah, I mean, you dig into directly of who gets access to the higher end and higher paying jobs. Typically, if you look at the data, it is not Black, Brown, or Indigenous folks. And so Black, Brown, Indigenous folks are working on the front lines. They are working as the nurses, as the bus drivers, as the mail deliverers. And they have to go to work every day. And what we see at the same study in San Francisco is that 70% of those that tested positive are working on the front lines as essential workers. It's no accident. And we have to take that data. And what I'm going to ask everyone watching and all the public health officials is that the same effort we're putting at addressing this pandemic today, I ask that we address the pandemic of social and structural racism and marginalization that occurred before the pandemic, and that's going to continue after it. But we can't let go once this pandemic flattens out.
Graham, you heard Edwin talk about a pandemic and racism. For a very long time, we talked about the epidemic of homelessness, especially in our region, in this part of Washington state. Now we have a health epidemic also impacting that epidemic of homelessness. How have things gone in that regard?
Well, I first off, have to echo a lot of what Aaron and Edwin said. It's funny, even though we're all coming from this from different perspectives, we have a lot of the same views. And, a lot of what I found in working with vehicle residents and people living in vehicles is that there's a wide diversity of people who are using mobile shelters as a form of affordable housing to stay connected to their historic communities and cities, for them to keep access to their medical systems, their veteran systems, education and employment systems, and that this group of people has been becoming disaffiliated, that they are being disconnected from the affiliated bonds of the society, and they're increasingly turning to vehicles and other forms of mobile shelter as their only alternative for housing in a total lapse otherwise. And so I think that it's, this is, I concur that we need to take what we are doing now and continue it after COVID, because, even yesterday, or maybe it was this morning, that California announced that they're planning on, they have a proposal to make housing a human right. And this is the kind of thing that people have been calling for within unhoused communities for, well, really for decades. And this is exactly where we need to be going, is thinking about how do we, rather than looking at homeless neighbors, the homeless community as this other that is unable to find the connection within our society, how do we focus on how to connect our neighbors with our communities, with the systems of care and support and education, as well as employment and housing? That it's, again, it goes back to this, this long-running assumption that it is just more and more housing, right? How do you end homelessness? You build more homes. It's, and I do agree that we need more housing, but it's that supply side focus that a lot of it has brought us to this point. That this is goes back to what Aaron was saying, that we need to be focusing more on how do we support the social service systems, the social support as a whole, so that our society can have the capacity to afford that housing that exists, to have the ability to get into that job that is paying well, that we can reduce those technical gaps that keep people of color, that keep people of LGBTQ groups and other groups that are kept down from society from getting access to jobs at Amazon, right? Because we need to find ways for, I would like to see that when we come out of this crisis, I'd like to see companies like Amazon step up and hire people directly from our unhoused communities, right? Because I think that that's where we need to be taking this work, is taking that sort of ultra step of how do we really heal this as a society and use this as a way to sort of, create a clean slate.
So, Graham, you're looking obviously at long-term, well, not long-term change, but necessarily systemic change that may occur as we start to think differently. Very concretely, as we approach this inflection point, as we begin to emerge from our homes and our social distancing and start to assess this situation, what do you foresee for the homeless populations in our area as we start to ask these deeper questions? What will be the impact on them in the next few months?
Well, it's a difficult time because a lot of the outreach providers are not able to be out. So there are a good amount that are out, but it's not the full staff. And a lot of those who are out are in a much more emergency response mode. So, the important data collection that we have about where are our needs, what are the levels of needs, and how do we address them, a lot of that isn't necessarily being captured at this moment. That information isn't being, sort of fed back up the pipeline. And so, that's creates a difficult time because, it's hard to say how many new people we may have that are experiencing homelessness. It's hard to see how many new people we may have that are moving into RVs. And, if we don't have the response of a parking space for that growing population before it really hits that apex of growth, we're going to be behind the ball on this. And we need to take more progressive steps.
Aaron, I know that you've been monitoring the various state responses as we begin to look at the reopening. And I'm curious what you're seeing and what you're thinking about in terms of how's this going to play out? I'm very much looking at the next 6 months in terms of thinking, okay, life has changed, but we are going to see each other face to face again. What does this really mean?
Yeah, well, that's a really good question. I mean, I think we all love to speculate about what's going to be happening. I mean, states are going to open up and local communities are going to open up. I think the pressure is on to try to heal the economic wounds, even as we try to lessen the health wounds. And I actually think, the people's I guess I have a level of faith in people's common sense that, it doesn't, in a sense, it doesn't matter what state governors declare. People are going to make their judgments about whether to go to the restaurants or go to the bars. And, I think the vast majority of people are going to be very, very reticent to put themselves, their loved ones, and their communities at risk by, flooding to, to the mall when they don't feel secure. So I expect that we're going to see a lot of that. I think, which means we're going to see spikes. We're going to see periodic spikes. And, I think our hope is that we can hold on long enough that a vaccine is available and can be produced and distributed to, people all over the world. It's not just the United States that we have to be concerned about. So I expect to see a lot of spikes, a lot of responses by communities to make sure that they can stay safe.
Edwin Aaron referred to testing and vaccines and how that might be available, ideally universally. What concerns you most as you think about the work that you're doing around that?
Yeah, and it's a good question to think about what the future looks like. And I want to clarify, I made the statement, the pandemic of racism, and there may be something, what does he mean by that? And I want to make it very concrete. So in this country, 50 to 55,000 Black folks die prematurely because of chronic illnesses. And those chronic illnesses don't happen because of some biological difference. They happen because of the conditions and the environment our communities live in, which are subpar. For example, you take Georgetown here in Seattle. Georgetown has the highest rate of respiratory disease. It's no accident. There are big rigs driving through Georgetown, dropping particulates into the backyards of our communities and children picking them up and them coming to the clinic with asthma. Well, guess what? Now that we are hit with COVID-19, who is most at risk? Those with respiratory disease, those with asthma. This is not an accident, again, like I said. And so thinking into the future, we have to contemplate where are the next inequities that we have to preemptively address. And sitting through this with my colleagues at UW Medicine and the health equity team, what we've been wrestling with is that when these vaccines do become available, our concern that, like influenza, 20 years ago, the mortality rates between Black and white folks was nearly 20% higher among Black folks for influenza, the common flu. Over 20 years, that disparity decreased because there is more access to flu vaccines. You can get them anywhere now. What I'm concerned about is that when these vaccines are available, that they may not be readily available and accessible to the communities who are most marginalized, socioeconomically depressed, and need it most. And so we have to contemplate, how do we make sure that these vaccines, and here's my proposition, just like the polio vaccine, where the inventor said, you know what, this isn't something that I should own, it should be owned by the public. And he made it public, and he made the patent public. I believe that the vaccine for COVID-19 should do the same, that it should become part of the public domain so that everyone has access to it, and that there aren't people dying of COVID when we know the cure, but the only reason they're dying is because they can't afford it, they don't live close to a hospital, or because they don't trust where it's coming from.
Yeah, that the whole idea of universality is definitely something that has been challenging us about this all along, and now we're seeing the sort of a competition or a race to find the vaccine. And so, how do we guarantee that universality? Is it a legal thing? Is it a policy thing? Is it just an IP thing? Because you're the lawyer. Is it intellectual property?
It's all of those things, right? We're talking about intellectual property law. We're talking about someone who's going to create it and say, this is my domain that I've created and I should own it, or a company that says that they should own it. And I respect individual property rights, absolutely, but this is beyond individual property rights. I'm asking at the moral compass of those folks that are fighting to cure this virus actually realize that it's much bigger than the paycheck that may be cashed into their account, but that this will fundamentally save lives in a magnitude that we can't fathom right now, because the communities that actually are more at risk just haven't been hit because it hasn't reached those communities yet. Here in Seattle, for example, we aren't seeing the great disparity, though we are seeing it in language. Those who have English as a second language seem to have a higher rate of transmission and being brought into the hospitals. But as it goes further south here in King County, I'm almost certain that the numbers we're going to see are increasing dramatically among Black, Brown, and Indigenous folks. So as far as the universalness of the vaccine, or making it public, it's going to take political will. It's going to take perhaps a necessity on the legislative front saying, look, can we call to the conscience of the communities of scientists, which scientists have proven and the frontline healthcare providers are proving, they will put it on the line, and they have been. But now we have to ask, will the pharmaceutical companies do the same?
Graham, Edwin was referring a lot to obviously universality, both in terms of access and ownership. And I'm now moving a little bit to some of the questions we're receiving from our audience, some thought exchange. And I'm going to combine what we just heard from Edwin with one of these questions. Is that the question was, how will we reach those without internet? It's a big equity issue. And I'm thinking very specifically about people who are living in their cars, who are homeless, both in terms of them being able to function, given that we have become so connected and reliant on our technology, and also once we do have testing and access to a vaccine, how are people who are homeless going to be able to benefit from this, given their constraints?
It's an excellent question, and again, I think it builds on what's been said just right before this. That particularly, I work a lot with people living in vehicles, but this is the same for tents and many communities or many places where forms of shelter that people occupy. That those shelters really aren't supported within our emergency shelter system. And so for people who live in vehicles, Edwin mentioned environmental racism, and for vehicle residents, there's a law in Seattle that says that any vehicle over 80 inches wide must park in industrial zones overnight. That's been that law since 1979. So, I mean, there's an level of environmental classism in a sense that occurs, and and there's been policies that have been happening over the last 10 years that have pushed all of the vehicle residents out of the north end of Seattle into those industrial zones in DeSoto. And so, absolutely the amount of particulates that are in the air there, the amount of people who have COPD, the amount of people who, even beyond the environmental conditions, but who have medical conditions, but there is no place for hospice in the emergency shelter system. And so they're now living at 90 years old with COPD behind a warehouse in Soto, right? That for many of these communities, first off, there is not a space into the services right now because there's no place to park their vehicle. And if there is not a place to park their vehicle that connects them to medical systems, and to those vaccines and all the systems of care around that, it is going to be extremely difficult for those people to have access to that. Because many of these vehicles, particularly these RVs, you can't park an RV that's 30 feet long down, outside of the, downtown emergency services center. It just won't work. And let alone the 3,300 people who live in vehicles in King County. And that's something to point out, is that in a couple of years ago, it was reported that over half of the people who live on the streets in King County are living in vehicles. Right. And so it's not a minor thing. It's not a trivial number. If there are not parking spaces that these people can use to connect to the medical systems, as well as the social services and the housing systems as a whole, we cannot effectively integrate this community into those systems of care. Right. And so it's fundamental that this has been a lapse. This has been something that has been a huge gap within our social service system in King County really for always. I mean, there really has never been the parking systems that need to be there. At most, there's been 20 parking spaces in Seattle for about 2,000 people living in vehicles. Wow. Right. So, I mean, it's beyond a tragedy. I think it's, I would say it borders on criminal. I don't know if I want to go that far, but it is a travesty. The lack of support that many of the people who are living on the streets currently have. And if we don't fix that, it is going to have a massive effect on their ability to access medical care and vaccine.
Thanks for that. Aaron, we're talking about big problems and maybe big solutions and universality. And you mentioned it in your first response, whether it's time for a universal basic income, right? And that has been a conversation we've been having almost for a decade now, as we think about even the impact of artificial intelligence and the fact that so many people are going to be out of jobs in the future, so we might as well pay them something to stay at home and still, eat and be able to survive. And so one of the questions we received from our audience is, isn't it time now for the freedom dividend or universal basic income? Because people aren't going to be able to afford the life that we have just because of this epidemic. And then obviously there's more technological disruption coming very soon. Might as well get in shape for that now, right?
Yeah, I think this epidemic has demonstrated probably better than anything in my career that health and well-being is a community responsibility, not an individual responsibility, right? All the things that Edwin and Graham have been saying, reveals the importance that we all, that we need to see in making sure that our neighbors are not only, housed, that they have access to health care when they need it, that they have income in order to support themselves and their families. So the sort of this notion of community bonding around the basic structures of our lives, I think has been revealed, in headlines now. So, universal, a basic income to make sure that people have support when they, when they've been when they're between jobs or they've run into hard times, to have housing available that's affordable when people run into hard times, and to make sure that people have health insurance regardless of whether they're working or in between or moving or from town to town, that health insurance access to healthcare is not dependent on those circumstances. So I mean, you couldn't, as a policy guy, I couldn't dream up a situation that revealed the importance of universality in all of these parts of our lives than the coronavirus.
It's interesting, and I want to put this to all three of you, and whoever wants to answer it first, put up their hand. But what we're talking about is almost bordering on revolution in terms of thinking very differently in our democratic capitalist society about how we're going to move forward based on all the challenges that we have and how this virus has exacerbated it. So my question to you is this: is that you're actually trying to appeal to our better nature by saying we should be more selfless, but it seems like there's actually a great opportunity for us to think selfishly to motivate us, because if our neighbors are sick, if the people who are homeless around us are sick, if communities of color and the students who are in our kids' school are sick, then we are affected by this as well. So it's in our best interest for everybody to be taken care of as universally as possible. How can we get to that narrative to actually start seeing some policy change? Who would like to answer that first? Aaron will like to do it. Okay.
Okay, so I'll just take a shot in my field, in healthcare. So, we've been debating for 100 years about whether we should have a universal healthcare system and universal insurance. Medicare for all, of course, is a term we use now because of the presidential campaign. And it's always been a fight between those who believe it's a human right and those who believe that people have to make their own decisions, and it's up to them. Well, this epidemic has shown that it's in my best interest for Edwin to have health insurance. I don't want to go to the store and have to worry about, is somebody walking around this store who doesn't have money, they don't have health insurance, they have some symptoms, but they don't want to go to the doctor to check things out. I don't want to be in that position. That's a threat to me. So, to me, this is, it's clear as a bell. And these discussions are going on now, both at the state level and at the national level, that are taking this discussion to this next stage, because the pandemic has revealed how important it is for us to all be covered all the time to make sure that our communities are protected.
In my best interest to be universal in our approach. Did either Edwin or Graham want to respond and add to that at all? Oh, there's Graham.
Yeah. So yeah, and again, echoing a lot of what Aaron just said, I think that, and kind of touching on what I said earlier, that I actually don't think that we need all that new of a response. I think that we have done the response before, and that as someone who's studied unhoused and communities and homelessness within the United States, that less than 100 years ago, there were 2 million people who were homeless and wandering across this country, called the hobo and tramp armies. And that was directly the result of about 200 years of very supply side oriented models that focused on reducing the costs on production on large manufacturers and large kind of monopoly corporate business holders. And I think that it was exactly it was the Great Depression to refocus that. Now, of course, there were a lot of as Edwin pointed out, there's a lot of negative sides to the New Deal, such as redlining as well. But we have an opportunity to not do a lot of those things and to do a lot better. But I would say that model that helped to get the U.S. out of the Depression is exactly where we need to go. And it was exactly the point that in the 1970s, when we reversed that model, that brought us to the point that we're at now. That the reason why we're in the position we are with COVID-19 and the unhoused community sort of rise that we've seen over the last several decades is specifically because of the last 40 years of policy that has brought us to this point. And we need to go back to exactly the changes, or maybe a more progressive sense, or a more helpful sense of those changes in a modern sense, that helped to get us out of these same situations 70 years ago, 80 years ago. I think that we can do it again, and I think that we can be successful in that as a society.
That's a powerful observation.
We need the identity of seeing that we can do this together. We need that cultural identity of saying we are together in this as a unit. It's that abbasiad, as it's called, right? That identity of the cultural unity around overcoming this great challenge.
Edwin, I'm going to give you the last word, and you can either choose to respond and continue this narrative thread. I also have a very specific question from our audience that I thought you'd be most appropriate to answer. So I'll give you the question, but also I think that what Graham just said sort of speaks to what you've been thinking about community identity. So here's the question. What are thoughts on healthcare for incarcerated, detained individuals, systemic issues, especially for people of color, LGBTQ+, youth, neurodiverse folk, culminate with the justice system, and so how it makes their healthy return to the community impossible. So maybe you can give us a grand wrap-up that also specifically responds to that question.
Yeah, and it's such a good question. Whoever asked that, I want to thank you personally. So I'll follow up on the previous question quickly, that COVID-19 has created the shock in our economy, in our country, to the point where it transformed how we discuss labor, where workers who have historically been viewed as dismissed, kind of necessary, but don't really think about it, to now they're being defined as essential. They have always been essential, but the comfort of the society we had lived in allowed us to not view it as such. And I hope, again, that this shock allows us to continue the narrative to realize we may be underpaying, underinsuring, and undercaring for communities that actually make our country run. We then turn to the question of incarceration in the carceral system. There are people right now sitting in jail who are in a cell with someone who is COVID-19 positive. They did not go to jail or prison for a death sentence from COVID-19, but that may happen. And the sad part is the 13th Amendment in this country, I don't mean to take us back to middle school in our history lesson, but the 13th Amendment, many people believe told us that it abolished slavery. And the truth is it really didn't. There's a huge caveat in the 13th Amendment. It says, slavery shall be abolished, and I'm paraphrasing here, slavery shall be abolished, comma, except if you are duly convicted of a crime. So that means the 2 million incarcerated folks in the United States are effectively property of the state. And what is the state saying about those individuals? That they have no humanity, and that we don't actually have to give them the same care as anyone else during this health pandemic. And it's sad because we do treat them as slaves. You have folks incarcerated who work for the top 20 Fortune 500 companies for production purposes, making 20 to 60 cents a day. And most folks don't know it. They're picking up the phones when you call customer service. They are boxing things that get sent to your house. Unless we understand the severity of how our carceral system works, and the understanding that it's a carceral system that was intended, starting from the Black codes, focused on incarcerating Black folks later than brown and Asian folks, because slavery had been abolished. Then you fast forward into segregation. And we look at segregation, and much of that is what's occurring with our prison system. But if we come out of the prison system, we have de facto segregation right now during COVID-19. Look who gets to go to the parks, and look who doesn't. Look who gets to lay out in the sun on a beach towel, and who gets arrested and their face slammed with a police boot. It is night and day. We have a de facto segregationist approach to COVID-19 that is leaving Black and brown folks having to stay home or go to work without the safety measures of the PPE, but white folks that get to roam freely and arrest, or if we look at Ahmaud, a shooting because you were jogging in the street during a pandemic. So we really have to contemplate the fundamental essence of how this country was built and what it was built upon. Because until we understand the reality of that, then we're not actually trying to address it. We're just trying to make it sound nicer or suggest that maybe it can change if enough people change their heart. And I'm saying, I'm good with people changing hearts. I hope it happens, but we need people to change the laws. We need people to provide material conditions that are different than the ones that we currently live in. Because when we do that, then we change outcomes of the severities that we see today.
Well, thank you for that powerful close to our time together, Edwin Guillermo Lindo. And thank you, Graham Pruss and Aaron Katz, for this enlightening and really revealing conversation. Join us again next Thursday for something completely different, Love in the Time of COVID. And great news, our season has been extended. We've added another 3 shows that will take us until the end of June. So I invite you to sign up and participate in the entire series. Thank you all for participating in this important discussion. I'm Hanson Hossein. Good night.